All right, good morning, everybody. Welcome. Very glad you're here. I am thrilled today to start a six-part series that is going to focus on some of the challenges that we see in our state with a specific emphasis on the Edmond, North Oklahoma City area. Today, we're going to be talking about substance abuse and addiction. Just to give you a sense of what's to come, this week, substance abuse and addiction. Next week, we'll be talking about homelessness. The following week will be at-risk youth. The week after that will be criminal justice-involved populations. And then we will do mental health, mental illness, and we'll close out on homelessness. And so that'll be the six series that we do. I'm delighted this morning to be joined by Jessica Hawkins. Jessica is a very, very dear friend and a former colleague. I'm going to attempt to give your work history. Okay, so let's see how good I remember this. So feel free to correct me. Jessica's from Bartlesville. For those who are so inclined, her dad played on the University of Oklahoma football team for a number of years. From Bartlesville, she went to school at San Diego, right? And she stayed, I don't know why you left. I still haven't figured that out. She stayed in San Diego, and this is where I mess up. You either worked for American Cancer or Heart. I can't remember which one.
I first worked for a really large mental health agency there in Southern California, and then I was at Cancer.
Oh, Cancer. Mm-hmm. Came back to Oklahoma, reestablished roots here. Her first job back in Oklahoma was as the director of the Suicide Prevention Grant at the Oklahoma Department of Mental Health and Substance Abuse Services, and that's where I first met Jessica. I had the chance to go to work there and met Jessica, and with a matter of a couple of months, she became our director of prevention services for the Department of Mental Health. And she and I worked together for a number of years. After I left mental health, she stayed a number of years. She then left mental health to go to United Way, where she had a tenure as the chief of operations or chief of staff?
Chief of operations. Chief
of operations for United Way. And she recently left that, and she is now working for Healthy Minds Oklahoma, which is an initiative that is focused on helping Oklahomans achieve better access to mental health care and treatment of mental illness. Did I get that right?
You did a great job.
Okay. So I will tell you I owe Jessica a lot. As an ag econ guy, didn't know a whole lot about mental health when I ended up over there. And she was a trusted instructor to me and a trusted colleague. So today we're going to kind of weave our conversation through substance abuse, addiction, and some of the current science around that. And again, just to remind you, the purpose of this six-part series is to further the conversation within our community about how we can uniquely serve the needs of the community in which we live. We do that very vigorously through our mission imprint, specifically locally through Cross and Crown. But I think what data will tell us, and Jessica may touch on this some as we weave through our conversation, what data will tell us is many of the things that we think about is, oh, that's a problem in that part of Oklahoma City, is actually something that's happening in the very communities in which we live and worship. So I'm looking forward to the conversation. I'm going to start us with a quick prayer, and then Jessica and I are going to walk through a series of conversation points that we hope is informative to you. We're going to make sure that we allow time for Q&A to fill in any blanks of something that we might have covered or touched on that you want us to go into deeper detail. So with that, Father, we thank you for this opportunity to gather today. I thank you for Jessica. I thank you for her friendship. I thank you for the unique giftedness you have provided her. She is a leader in the field of making sure that Oklahomans have access to healthy minds, healthy bodies. I appreciate her championing the cause of those who need the engagement of your community. Bless this class. Let our words be instructional, and let them stimulate opportunities for us to serve your kingdom even more. Amen. All right. So again, I'm glad to have you here.
Yeah, thank you so much for having me.
We've kind of walked through. I remembered what your background was, but what got you focused on this as a career path? As you got out of San Diego and you did this, tell me a little bit what drew you to this idea of helping people who might be at risk of or actually chemically involved.
Well, good morning, everybody. Thank you again for having me here. And I think my story of coming into my career is really one of protection. My background, my passion in the field of mental health and substance use is around what we call primary prevention. And what we mean by that is, how do we work with young people and with adults around keeping them safe, healthy, productive, connected to their community, and really mitigate risk of harm from things like substance use and the devastation often of mental health problems. And so for me, growing up in Oklahoma, I would say I was afforded a lot of opportunity, a lot of privilege, and a lot of protection. I had a lot of buffers in my life that we now understand really matter. The science is really clear. We have about 50 years now of research that tells us those things that we sort of have had hunches about in young people's life that help certain people fare better as an adult and others not. We actually know what those things are. And when I look back at my own life and I think about my childhood and my family and the community I grew up in and the adults who were in my life and the school that I went to, all of those things really mattered. So one of my main messages and sort of missions around my work is to really help people understand that not only are diseases of addiction and mental health treatable, they're also preventable. And that's something that we don't talk about as much. It's difficult at times to think about loved ones and others who are suffering with substance use disorder, and to actually have the conversation that maybe there were ways that that could have been prevented. And while that's not the case for every single person who has substance use disorder, it definitely is a conversation and an understanding that we need to adopt as a community in order to really help give young people and young adults the best chance they can at a better life.
So as you walk through that answer, what immediately came to mind is you talk and educated me a lot about the subject matter of preventative factors and strength factors and things like that. Can you touch on kind of what you mean when we talk about the elements of good preventative factors and how that might play out in a community?
So just like we might think of heart disease or asthma as a chronic condition that has certain risk factors affiliated with it and certain protective factors, that is now how we understand how we treat and address substance use in the same sort of way. It's a complex disorder, but we know that there are certain individual level factors that can raise somebody's risk or predict, if you will, future substance use if those are present in their life as a child. The opposite of that is that we know that the absence of those risk factors and then some key protective factors really are at play, which help buffer young people and young adults from future problems with substances. And so we call these risk and protective factors, and it's a model that we use when we are trying to improve conditions in a community or in a family. Those risk factors, those protective factors happen at several levels. First of all, most people I think of the individual, like what's a risk factor for substance use for you and I? One might include exposure to alcohol and pregnancy. That is a demonstrated risk factor that can place a young person at future harm or future risk for their own substance use later in life. Also an example might be something like a skill. So young people who are taught really great coping skills or who are able to be resilient or have a resilient temperament are protective factors against future substance use. And there are dozens and dozens and dozens of these risk and protective factors. We talk a lot in this field about you and I and what puts you at risk, what puts me at risk, and we tend to think of those things of just within ourselves. But we also now know that there are risk factors that exist in neighborhoods, in communities, and in schools. And so the neighborhood that you grow up in matters. Your exposure to violence, for example, can place you at higher risk for future substance use. Your exposure to family disorganization is what we call it in the field, but really we mean a lot of unhealthy transitions in the home, loss of a parent, for example, to prison, jail, even divorce, separation like that. It can be traumatizing and be one of these risk factors, but there are many of them. Mm-hmm. And it doesn't necessarily mean that if you carry these risks or if you don't have these protections, that you will absolutely use substances. But just like with heart disease or with asthma, we understand that this condition is more likely for you, and can be more difficult to address or manage once you have it. So it's a complex phenomenon, if you will, and the way that we address this in communities is we have ways of sort of measuring risk and measuring protection among children, among their schools, among their communities, and then we can develop a plan to make sure we help boost the good things and really lower the things that are placing young people in our neighborhoods in harm's way.
So as far as a protective factor, I know that you and your family have a faith relationship that's kind of central to your rhythm, but if I remember correctly, the idea of religiosity is a definite protective factor that we see statistically that people who are engaged in a community of faith will typically have more resilience and more protective factors. Is the data still proving that to be true?
It is. So in the field, we call it religiosity. When we try and measure that, we're talking about several different factors. We're talking about belief in a higher order, a sort of a moral compass in some ways, is ways that we can talk with people no matter what their faith background about whether they possess that or not, or if that's developing for them. Also community. So you hit on something that is very important, that is becoming more and more important when we talk about substance use, is having a strong, connective, supportive, and compassionate community that you relate to, that you are obliged to, that you have regular supportive networks that you've developed is extremely protective. And the reverse of that would be, very socially isolated, unable to find support, particularly for young people who lack that type of anchoring adult or community or peer network, a healthy peer network in their life, can be quite risky and predict future problems.
So one of the ways, and this is a little deviation off of the guide, that just helps people visualize some of the change that has been occurring related to the environmental protection, if you will, is thinking about signage in convenience stores and what that might have looked like 25 years ago relative to walking in and you would find the windows covered in $2.87 a pack, or listing all the alcohol. So those are some of those environmental things that influence people's risk, right? Am I misinterpreting that?
No, you're spot on. So what you're talking about is community risk and community protection. So earlier we said it's not just up to you to have individual factors, whether it's a genetic predisposition to substance use or a family environment. Even when your individual and familial family risk factors are relatively low or moderate, you can be highly influenced by your social environment. And so where you grow up, as I said, really does matter. And what you're alluding to is what we call environmental risk. So exposure to substances is incredibly important in whether or not a young person develops risk for substance use later in life. That can come in the form of having substance use in the home. It can come in the form of peers that are using substances and offering substances. We call it availability or access. So if you live in a community that has a very high number of, let's say, marijuana or alcohol or tobacco outlets, and there's high repetitive exposure to young people for these substances, they are more likely to use. And so we also look at factors like price, interestingly. We might talk a little bit about drugs like methamphetamine and opioids here in a second, but price really matters. So when you have a substance in the community that's incredibly cheap, easy to get, socially promoted, these are the messages that are coming in all day long to young people directly and indirectly, and send a message about normative use, that using these substances is normal, it's what lots of people do. I see so-and-so using and so buying at the convenience store. As these messages come in over and over and over again, you can imagine the influence that it has on an adolescent brain and development. And so we don't just have to build really great skills in individuals and in families. We don't just have to treat individual people and make sure they're on the right path. We also have to really zoom out and think about the community at large, and what we call the built environment that young people grow up in makes a difference for their health.
Within the last decade, there have been two seismic shifts in public health policy in the state of Oklahoma relative to access to products that 2 decades ago we would have never imagined in Oklahoma, the wide availability. That would include what would be under the policy realm was argued as alcohol modernization, right? There was that one, and then what the voters did on the state question relative to cannabis availability. And, you know, within this body, there may be a wide range of feelings whether or not those were the right policies. The policymakers and the people of Oklahoma have expressed that, so now they are entrenched as part of our society. From a observational and statistical standpoint, since those two elements have become more widely accepted in our community, are there any observations you can provide about statistically what we're beginning to see, or any trends that are emerging with the greater availability?
Well, right now it's interesting. We don't have a lot of longitudinal data quite yet about these two changes you're referring to, but we will. We do know that at the time that marijuana legalization occurred in Oklahoma, if you were to take the trend line back for youth substance use very far back, what you would see is that we'd made some really important gains over many decades in reducing youth substance use. The one area that we had not over time was marijuana consumption, and it had stayed stubbornly stable. And in the last several years, we've seen a bit of a bump. And so, you know, it stands to reason, even though we still need the research and the data to come out to help us understand the impact on communities and on young people, but it stands to reason that some of these environmental factors that we're talking about contribute. They contribute to risk. And so when we look at policy from a mental health lens or from a public health lens, some of the questions that we ask are, because we have legalized marijuana or more widely available alcohol now in Oklahoma, what are the, again, protective factors or the buffers that we can bring in to make sure that young people don't have easy access, that retailers are checking identification, that advertising is not using cartoon characters or you know, other sort of images that are attractive to young people. Some states have gone as far to make sure that window advertising and outside billboards and signage are at a minimum, that they don't cover a certain percentage of windows, not only for safety, so law enforcement can see in, but also so there's just not this level of saturation of messaging around pro-use. For young people. And so that is one very small example of many that are conversations yet to be had in terms of looking at what Oklahoma now has and whether that's working well, not well, how can we adjust? And through policy, that is one way that communities actually can make adjustments. So in terms of what you're seeing in Edmond or in your community, communities have a voice in being able to design and maybe improve upon policies that have taken place a couple of years ago. So it's a new environment for Oklahoma and for young people, and we have to make sure that the messages we deliver to young people really emphasize things like safety, like future risk for other developing problems. We have a survey that's done in Oklahoma that helps us understand the level of use that's going on with young people. And we know that the average age of alcohol use, for example, for young people in Oklahoma is around age 12, which is too young for the developing brain. We know that the adolescent brain is going through a massive amount of change during that age frame, and that our brains actually don't finish developing until around age 25. And so some states and communities have really looked at things like brain science to help us think about, well, what would be the appropriate age to introduce a substance if somebody were to choose to do that? And it's probably around, 21 to 25 if that were to take place. Your risk goes way down for serious consequences if you were to use at a much later age. So in the world of prevention and mental health, we think about things like how can we delay use, even if it's several years, that can help make people safer and reduce risk for future problems.
Right. Cannabis and alcohol aside, and let me underscore as I transition to this next question, inappropriate use of both can have very significant consequences. There's no doubt, but that may be what is most on our mind, especially as you drive around and see the number of dispensaries as you wind your way through Oklahoma City. But Oklahoma has historically and continues to face some significant challenges with other illegal drugs, both those that are legal that are misused, as well as those that are illegal. Talk a little bit about the current environment, about the addictive properties and some of the trends and some of the other drugs of choice that have emerged in our communities.
Okay, and I'll just say one word about alcohol and marijuana. For somebody like me who focuses a lot on youth prevention, and why this matters is because one of the risk factors that we were talking about earlier, that I mentioned earlier, that can predict future problems in adulthood is early initiation of drug use. And so we focus on alcohol and marijuana a lot because that is often the first substance that young people have available to them, or that is in the community and accessible to them. So it's, it makes sense that for young people who are using, that is the first substance that's being introduced to them. And their use of alcohol and marijuana is a risk factor for future problems. And so that's why we care. Also because of the consequences of intoxication, obviously. But when you raise the issue of trends in other drugs, we have a serious problem in Oklahoma right now with opioids. I'm sure you're aware. The country has been in what we call an opioid epidemic for many years now. Oklahoma has really had a very heavy burden around opioid misuse, in that our rates of opioid overdose are much higher than the US. We had and enjoyed a period of time where we actually saw that trend change. When there was a lot of attention paid to how people were obtaining opioids, and it was largely through prescriptions and prescribing practices at the time that were not following the research. And so what we were seeing in Oklahoma and throughout the country were opioid manufacturers and distributors who were not telling the truth about how their drugs should be used, and it was way overprescribed for things like chronic pain. We now understand that use of opioids for chronic pain is not helpful, that opioids are probably most helpful for very short course pain, like 1 to 3 days, maybe after a dental procedure or a broken bone. But long-term chronic use of opioids is not effective for pain, and it's highly addictive. And so like alcohol and marijuana, what we had in Oklahoma for a time is a very large amount of exposure of a substance on a very large number of people, which is unusual in substance use. Normally we don't see a highly addictive drug like that reaching the thousands and thousands of people that it did through the opioid epidemic. And so we have continued to struggle despite our gains in prescription opioid-related problems, which have gone down. We're very happy about that. What we are now in is what we're calling the fourth wave of the opioid epidemic. And we're seeing illicit opioids come onto the scene and sort of backfill this demand for opioids. And those are things like fentanyl. And you all may have heard about fentanyl, but it's a highly potent opioid that is illicit. You do not get it through prescription, at least the fentanyl that I'm talking about. And it's manufactured, typically comes up through Mexico and is widely available. It's very, very cheap. And so it's often used to cut other drugs, and it's circulating in the drug supply right now. And so most overdoses right now, overdose deaths in Oklahoma, are being caused by illicit fentanyl. And the next drug I'll talk about is methamphetamine, because that is the second drug that is most responsible for our overdose deaths in Oklahoma. We have seen stimulants, methamphetamine, really come back onto the scene in Oklahoma, and it is largely due to our opioid crisis. And you might say, why is that? It's a completely different drug. Don't understand the connection. The connection is this: we have a lot of co-use going on, people who are using both opioids and stimulants, and you might ask why. Number one, it could be for the synergistic effect or the euphoria that's created when using both, but for a lot of people, interestingly, they're reporting that they are using methamphetamine as a way to titrate themselves or get off of their opioid. In order to recover or be treated from opioids, it can be an incredibly painful process to come off of an opioid. And if you do not have proper medication and treatment when you're trying to lessen your opioid use, you have physical symptoms, physical reaction to withdrawing from opioids. And so if you're able to access methamphetamine, back to availability, if you're able to access methamphetamine and it can help you cope with the withdrawal symptoms from your opioid, you will take it. It is a sort of a desperation and a way that people are actually trying to treat themselves when they don't have access to good treatment. And so there are more reasons than that people are co-using or that methamphetamine use has gone way up. The other one that I would add is that it's incredibly cheap right now and very abundant. And so back to the risk factor of availability and accessibility in our community, we just happen to be a time where illicit methamphetamine is not being manufactured in small batches. You may have heard back in the early 2000s, Oklahoma was sort of known for this bathtub methamphetamine. These were small batches made locally in people's homes. That is not the case anymore. Methamphetamine is being abundantly manufactured, brought into the community. It is very, very cheap, very easy to get. And for many people, as I described, they may be using it, in fact, to escape an opioid addiction. So it's caused an incredibly complex situation in the community, and one that we may actually be able to help address with better access to treatment.
So I would be remiss if I didn't, as you talk about methamphetamine, just to articulate how hard it is from a policy standpoint to chase these. There was a period of time, late 2000, first decade of 2000 to early part of the second decade, that methamphetamine had significantly been driven out of the state. And that was through public policy. And for those of us that are chronic allergy sufferers, we may have hated the removal of pseudoephedrine because it was, when used appropriately, was something that worked. Methamphetamine use in Oklahoma really bottomed out. When you do good policy, people will find ways to backdoor that policy, and so now you have significant methamphetamine trade from the cartels coming into the country. One thing that I will pause here and go off script because I want to talk about something kind of as a myth buster, if you will. Jessica's career has had many accomplishments, but one of those that when she looks back and retires, she is, to her credit, I would consider her the lead champion, lead voice on the availability of naloxone in our state through both public policy and some purchasing decisions you made when you were our director of prevention services. Naloxone has become widely available and widely accepted in our community. And naloxone was just made over the counter.
That's correct.
So you can now go into a Walgreens and buy naloxone. Some people may say, A, what is naloxone? And B, why would I want to have that product? So as a strategy for making sure that we're in a position to save lives, why would somebody want to have naloxone?
So the reason that opioids became such crisis levels, not only the addiction that comes and the compulsion that comes with needing more and more opioids to get the same amount of effect that you originally received. If you've ever been on opioids for a long time after a broken bone, you know that at some point it starts to level out and you need a little bit more and a little bit more. And that's why these short courses are important, but one of its major problems is that in high quantities, especially and often for people who are opioid naive, they haven't taken opioids before, or they're taking more and more and more to get the same effect, is that it's deadly. It's a respiratory problem that occurs. That opioid stops your breathing. And so how do people pass away or get injured through opioid overdose is they stop breathing, they nod out, head goes down, and they pass away if somebody does not intervene quickly enough. Most people who are using opioids use alone. This is not a situation, I don't know if any of you know anybody or if you yourself have had substance use disorder or use opioids, but in most cases when you're using alone, it's very unsafe. And in some cases, in many cases, you may or may not have somebody nearby to help. So for many, many years, decades now, the ambulances have carried naloxone. It's a medication that's called an opioid antagonist, and it knocks the opioid off the brain receptor that's causing that respiratory depression, and it restores breathing. That's all it does. It's a very simple medication, very safe. If you use naloxone for the far majority of people, it would be very rare to have an event. It's like water. It really has no other effect. If you have no opioids in your system, there's nothing for it to do. So several years ago, many communities across the country started looking at making naloxone more widely available so that you didn't have to have an ambulance come to your house in order to even get this drug. And so manufacturers made it into a nasal spray, and states like ours decided to purchase it and start to make it more and more available. The first stop was we worked with law enforcement officers to make sure, especially in rural communities where ambulances are very far away, but police or sheriffs could arrive first. We wanted to make sure that police officers had naloxone in their cars. Then we started working with fire departments, and then it extended to things like universities or school settings, and then family and friends. At the end of the day, if you're living with, or if you know or care about somebody who has opioid use disorder, or who's simply getting an opioid prescription and is using it, like my mother, is using it for a sort of end-of-life situation, we want to make sure that we have this safety measure in our home. And so now it is widely available, very easy to use as a nasal spray. I carry it in my purse wherever that went. I have 3 doses with me all the time, just in case. It's one of those things that we think about if you have a loved one who you're really worried about, or somebody who you really wish would get treatment. We need them to stay alive. And we had a law enforcement officer one time work with us, and working with a law enforcement crowd, and there were some in the crowd that really was not in favor of this. They didn't want to turn into first responders. They didn't think that people who were using and making that choice really, were a population or somebody that they particularly wanted to help in that way. And he used to stand up in front of his peers and say, if it were your friend, your brother, your neighbor, how many times would you save them? Just once? Just the one time? And then it's on them? And I think that really helps put into context that, no, we want to make sure that even our loved ones who are currently using or who have risk for this and need this stay safe, so that we can help them get into care and get into treatment, recover, and live a full life.
So, and then from a even beyond use aspect, specifically with fentanyl, there is an environmental element of fentanyl to where it can occasionally impact someone who may not be using, just environmentally, correct?
That's right. We have heard cases where others who are not intending to use fentanyl are being exposed to fentanyl. I don't want to overstate some of these, because in some cases we're not entirely sure what was at play when somebody overdoses, and we sort of walk that back and try and figure out what happened. But there have been anecdotal reports that fentanyl is showing up in vape pens or in substances. You may be using substances that you've used for a long time with a friend, with a buddy. Now you use it and it has some measure of fentanyl in it. You had no idea that you were ingesting fentanyl. Fentanyl is an opioid, just like your hydrocodone. It's a very powerful one, and your other opioids, but having naloxone in the community really matters right now.
Yeah, so I think the take-home message might be for people as they contemplate this, and then we're going to wrap up with one question, so I'm going to combine 2 of them. I think the wrap-up message is naloxone can save lives. Absolutely. It is widely available. it probably makes sense that if you are a place of employment, if you perhaps are a church, just as you might have a defib device in your presence, it makes sense to have naloxone on premises.
It is becoming much more standard as part of your standard fare safety kit that you would have as an employer, as a large organization, to make sure you're prepared, particularly if you're far from ambulance or emergency services.
So the final question, and this points to what we wanted to accomplish today, but I'm going to combine two of the questions. Just a couple of comments about the relapse recovery process as it relates to addiction. And then any comments you can make to bring it home to this area of local ministry, North Oklahoma City, Edmond, anything, any tidbits of information that you can share that might help us as we mull how we might better serve our community in the future.
Okay, there's a lot in that.
There's a lot.
But I will be quick. So just to restate that substance use disorder is a treatable chronic condition, just like heart disease or asthma. And we would much less call it that you would be cured through treatment for substance use disorder, just like for asthma and heart disease, as opposed to something more like you would manage that chronic disease for a lifetime. And so for many, many people, because this is a complex problem, substance use disorder can take 2, 3, and 4, on average, very serious attempts at treatment. That may look like residential treatment, medication, talk therapy, but it can take quite a while to achieve a certain level of recovery. When we use the word recovery, that's a very personalized process of trying to achieve a state of well-being that keeps you safe, keeps you symptom-free as much as possible. And there are many ways that a community or a family or a group like this can support people in recovery and prevent relapse or help somebody manage their condition. There actually have been studied several key things that really promote recovery for a long time, and if you don't have these things, you see a lot more relapse. One is safe and stable housing, and I know that's one conversation that you all may be having. Another is having purpose and meaning in your life, so having daily activities that bring meaning, such as school, a job, volunteerism, creative outlets, things like that. And in addition to that, we talked about a protective factor of connection. Being connected to a larger and safe community is critically important for recovery. And so these are the ways that we can support people who are trying to manage this disease for a long time. And when talking about Edmond and North Oklahoma City, we see some really positive things happening in the community, and we see some serious challenges. So if housing is a major barrier to somebody's recovery, we have to talk about what that looks like in North Oklahoma City and Edmond. And right now you might be seeing the city of Edmond doing housing and homelessness studies, and they're finding that the average new home in Edmond is well over $400,000, out of the reach of many people who need safe and stable housing. If you think about the population of people with substance use disorder trying to recover, this is an incredibly difficult thing to attain in this area. Transportation can be a major barrier in this part of the state, where people are trying to get into treatment programs and they have to physically get themselves to classes and to counseling sessions, while also maintaining a job and taking care of childcare. These sort of life events that we all have, when you put on top of that trying to manage and get treatment for substance use disorder, is an incredibly difficult climb for many, many people. And so these are the types of things we want to ask ourselves about living in this area, about whether we have easily accessible treatment. Can people afford it? Is there a place to go? Do we have a qualified workforce who can see the number of people in Edmond and North Oklahoma City who need these services? Right now, the answer is no. We need more of those services. On the plus side, which I'll end with that, is that the city of Edmond in particular has been doing some wonderful work in looking at mental health in the community. There is a new comprehensive mental health center that is coming into Edmond called North Care. They've opened a new outpatient clinic in the community over on 9th and Bryant, and by January they'll have a new crisis center and sort of sobering center and place for assessment and crisis over on 15th and Kelly. And so we see some new services coming into the community, which is incredibly important. And anything that the community at large can do to support and sort of wrap around and provide other sort of compassionate services and help with these issues of life, childcare, transportation, access to treatment, community, connection, meaningful activities of daily living. These sort of things are vitally important to making sure that people in this area can recover and live fruitful lives.
As you and I have done many times in offices through the years, we've exhausted all of our time. So you can hang around for a couple of minutes. If people have questions, they can say hello or anything. But I hope this has been helpful to you. If you have any questions that you don't get answered today, drop me an email, and I'll get Jessica to help me do that. We need to be respectful of our next transition time. So, Jessica, thank you. I appreciate you coming and spending this morning with us.